Very much. Thank you very much. Thank you, Dr. Manuel. Ayun, keep.
Good morning. Thank you, Dr. Manuel. Thank you, Dr. Ranyoa. Good morning. I'm Dr. Kit Dizon. I'll be moderating the third interesting case presentation for this morning, and the topic is computer-assisted rod construct for a thoracolumbosacral ependymoma, to be presented by Dr. Daniel William Yu of Chong Hua Hospital from Cebu.
Hello, good morning. Thank you for this opportunity to present entitled Computer-Assisted Multi-Rod Construct for a Thoracolumbar Ependymoma. So I'm Daniel Yu, the current spine fellow of Chong Hua Hospital, and the surgeons involved in the case are the following. So we have Dr. Morales, Dr. Benarmino, Dr. Gitataras, Dr. Alimbayugan, and Dr. Villegas. So instrumental long spinal fusion to the sacrum is commonly indicated for a variety of cases that covers degenerative, traumatic, deformity, and tumor. This, however, is not without complications. Common complications are nerve root injury, loss of alignment, implant failure such as rod fracture, and pseudoarthrosis. Adult spinal deformity surgery goes as high as 12% that requires operation, and amongst those common causes would be rod breakage and pseudoarthrosis. So risk factors for rod breakage includes advanced age, high BMI, previous spine surgery, large pelvic tilt and thoracic kyphosis preoperatively, and pedicle subtraction osteotomies. Pseudoarthrosis is particularly prevalent, especially to the destabilized site, usually at sites where 3 column osteotomies are done, and at the lumbosacral junction, which showed that area has a high biomechanical stress from load and shear forces. A mechanical study of multi-rods showed that comparing multi-rod to double rod technique, multi-rod construct had significantly improved stability and reduced lumbosacral motion, inflection, and extension, and also significantly improved stability in left to right axial rotation when crossing together. So, focusing more on rod breakage and pseudoarthrosis, it has been shown that dual rod technique had significantly greater incidence of rod breakage and pseudoarthrosis as compared to multi-rod technique. With this, we go to our case. So we have a 27-year-old male civil engineer came with a chief complaint of bilateral lower extremity weakness. So history actually started 2 years prior, last 2020. Initially presented with severe low back pain with radiculopathy on the bilateral lower extremity. Patient presented with no motor, nor sensory, nor bowel bladder problem. An MRI was done revealing a 10 cm contrast enhancing intradural mass within the lumbar thecal sac extending from L2 to S1 level. Initial consideration at that time was myxopapillary ependymoma versus schwannoma. At that time, patient was assessed to have an intradural mass. Consideration was ependymoma versus schwannoma. However, due to the pandemic, patient was lost to follow up. And here, patient came in for consult, still with severe back pain, but now with bilateral lower extremity weakness and sensory deficit. And noted inability to ambulate due to the weakness. For physical examination, there was no spinous process tenderness nor gross deformity on the back, hyperreflexive on the bilateral lower extremity, no pathologic reflexes, intact perianal sensation with tight sphincteric tone. Last normal sensation would be around T12 area. And for the manual muscle testing, so we graded L2, right side L2 to be 2 out of 5. And then for the left is 1/5. For L3, for the right is 1/5. And the rest are graded 0/5. The sensation on the right side is 70%, where in the left side is 50%. So these are the lumbar AP and lateral radiograph of the patient. Focusing more on the lateral, we can see that the posterior element and then the posterior wall of the lumbar segments are already lies. With the following measurements, so we have a lumbar lordosis of 15 degrees, pelvic incidence of 44 degrees, sacral slope of 26 degrees, and pelvic tilt of 18 degrees. So these are the CT scan image of the patient. On the left, we have the sagittal cuts, and on the right, we have the axial cuts. Noting on the sagittal cuts, we can see that there's already scalloping of the posterior wall of the lumbar segments caused by the tumor impression. And focusing on the axial cuts, we can see that specifically on the L2, L3, L4 area, the pedicles are already involved. They are already thinned out due to the tumor. So this would be the latest MRI preoperatively. So we can see on the T2 weighted image, sagittal cuts, that the tumor has already progressed. Previously, it only involved L2 to S1, but now it involved up until T11 area. And on sagittal, we can also see that there's already scalloping of the lumbar posterior wall. These are the axial cuts, T2-weighted axial cuts of the lumbar area. So with that, we assess the patient to have paraplegia secondary to incomplete spinal cord compression, last normal T12, fractal C secondary to interdural mass from T11 to S1, in which we did a computer-assisted spine surgery, posterior decompression, excision of interdural mass, and biopsy of T11 to S1, instrumented stabilization using multi-rod technique from T8 to ilia. So moving on to our operative technique. So we place the patient prone under general anesthesia with neuromonitoring, and the diagram on the right is our setup during the OR. So we did a posterior mid-eye incision to expose T7 to S2 level, and did a pedicle insertion under computer navigation. Now, with the help of the brain lab computer navigation, we were able to maximize the diameter and the length of the screws as tabulated in this slide. Also, with the help of brain lab computer navigation, we were able to do a preoperative pedicle screw trajectory planning. As you can see, the top image is the pedicle screw trajectory for T8, so we directed it in a parallel manner. And on the T9, we directed the pedicle screw in a we medially directed the pedicle screw. So with this, it helped us with the application of the multi-rod. So we did the laminectomy from T10 S2 level. So on the right side, we have the picture of the dura exposed. And we're in the neurosurgery service, did the tumor excision. So in this picture, the coda equina is retracted laterally. And this picture, the central part is the posterior longitudinal ligament, and we can also appreciate the scalloping of the posterior wall of the lumbar vertebrae. After the tumor excision, we repaired the dura. So for the proximal, we were able to do the primary repair, but for the distal, we used dura patch close in the dura. So finally, we placed in the rods, set screws, and crosslink. So this would be the final intraoperative picture. So we have a multi-rod, 4 rods all in all, and 4 cross links used for this operation. So total OR time is 11 hours with a blood loss of 1,500 cc, and monitor showed improvement in MEP over left gastrocs and tibialis anterior after the decompression. So these are the immediate postoperative X-rays. And biopsy result consistent with grade 2 ependymoma. So the dressing change would be on the picture on the right side. And postoperatively, we noted improvement in sensory from 70% and 50% to 90% on the bilateral lower extremity. So preoperatively, patients were not able to sit upright independently without backrest due to pain. But post-operatively, after operation, patient was able to tolerate to sit without back support pain-free. So at 3 months follow-up, here are the radiograph for the AP and lateral lumbosacral images showing there are no signs of implant failure. And this would be the video. So patient was able to diligently do rehab, and at 3 months, with the help of the physical therapist and functional electrical stimulation, patient was able to do assisted sit to stand. So at 6 months follow-up, here are the radiograph, still showing no signs of implant failure. And here are the eggshell cuts of the CT scan. Now, this showed the trajectory of the screw. So we have the parallel oriented pedicle screws for T8. And an example of the medially directed screws would be on the T9. So this would be the L5 to iliac CT scan image. And 6 months follow-up, patient now able to do assisted ambulation. Okay. So in conclusion, construct spinal stabilization for long lumbosacral segment is a viable option. It's not only used in treating adult spinal deformity as commonly described in journals, but also in treating unstable spine caused by tumor. With that, I end my presentation. Thank you very much.
Okay. Thank you, Dr. Yu, for the presentation. That's a very interesting and very nicely done surgery. The floor is now open for questions. Yes, Miko.
Hello, hello, can you hear me? Hello?
Yes, sir.
All right, congratulations on a great case. Actually, one of my main questions for you, do you know what is the failure rate of a very long construct with regards to a spinal deformity case that you've been doing a T8 to the pelvis fixation? Especially you have a middle segment which is not instrumented, and then you also have a lower base segment which did not have any structural support in terms of whether an interbody fusion. No, my biggest worry with these types of cases is the failure rate. I know the concept of multi-rod constructs will help augment or at least decrease the chances of failure, but in terms of overall techniques, and probably for me, it should have been maybe a good way to at least decrease possible complications in the future is to have instrumented the other bodies as well, and probably put in an interbody, especially on the base. I know that this is more or less a type 2 Russelli type of sacrum. So in terms of failure rate, since you have the pelvic incidence, which is only at 44, eh medyo mababa naman, no? But still, do you know what is the reported problems or rates of failure for these cases? Thank you.
Thank you for the question. Now, regarding long spinal fusion, so I come across one journal comparing those who had multi-rod and dual rod. It showed almost half of those dual rod that had long fusion developed rod breakage or pseudoarthrosis over the segments compared to the multi-rod, those patients who had multi-rod. But regarding the specific incidence for our case in which this middle segment is not instrumented and we didn't have any interbody fusion, I still have to check on the literature regarding it, sir. But the question is very nice, and I will look at it, sir.
Okay. Are you satisfied? Okay, Dr. Mario Vera this time.
Thank you. That's a nice case. But we were just discussing with my seatmate here. This is an intradural long tumor, isn't it? So,
Yes, sir.
I mean, why were you not able to do instrumentation in that laminectomized portion? Was it because you sacrificed what, the pedicles or facets, and therefore you cannot put fixation in that level? So that's because that's a problem. As mentioned, you have a long skip area that was not instrumented, and it's a very long construct, so the rate of failure will be very high. So what was the reason why it was not instrumented? Is it okay?
Yes, sir. Thank you, sir, for the question. So preoperatively, when we did the CT scan, it's on eggshell cuts. It showed that on the L2 up until L4 area, the pedicles are already lysed due to the tumor impression, bone erosion caused by the tumor. So there was no pedicle already for those segments.
Okay. Yes, Jomic.
Nice case, Daniel.
Thank you, sir.
With regards to post-op, did you prescribe a TLSO brace for your patient? Kasi I think it would be quite important before, especially after you're waiting for the fusion to happen. I have the same concerns as Miko with regards to failure rates for the long construct, especially you weren't able to instrument the lumbar segment. So I think, well, it would be prudent to put your patient on a TLSO brace, especially even with sitting, with just the sudden bending, because pwede maunahan ng rod breakage. And what augments did you do for the fusion? Did you just do local bone grafting?
Thank you, sir, for the question. So, post-operatively, we place the patient on a TLSO brace, and for the intraoperative technique, so we put in bone graft.
Local bone graft from
Yes,
the
sir.
laminectomized areas, yeah.
Yes, sir. And we also put in synthetic bone graft. We added up synthetic bone graft, sir.
Thank you.
Thank you, sir.
Okay, sir.
It's a really tough case, no? And that's not just from the stabilization, but also from the taking out the intradural tumor. I would expect this actually to be a myxopapillary ependymoma specifically, not just an ependymoma based on the location. WHO grading would still be grade 2, but you really have to watch out for residual or recurrent tumor in the future. So does this patient have bowel and bladder symptoms up to now, which would be very common for these cases?
I thank you for the question, sir. For our patient, the patient did not have bowel bladder problem preoperatively and postoperatively, sir.
Okay, congratulations on that. And how do you intend to monitor for the intradural tumor? I mean, the status of this tumor in terms of imaging.
So we can do, number one, clinically, we can check for symptoms. And number two, for imaging, we can do a repeat MRI to monitor for any signs of recurrence, sir.
I would suggest probably an MRI at the 3-month mark. And then depending on what you get, if you have residual tumor, you have to monitor them very closely. And then if there is no tumor, at least a yearly MRI thereafter. Okay, thank you.
Yes, Dr. Dave.
How good was the seal on the dura, the repair post-op?
So after they repaired, they did a Valsalva. No leak was noted intraoperatively, sir.
Okay, and that was sustained post-op. You think the control is good? Kasi yun yung isang pwede maging problema, di ba? If you have a persistent CSF leak that can lead to pseudarthrosis, and if you have pseudarthrosis, then eventually your construct will fail.
Yes, sir. Thank you, sir.
I think Dr. Tanyente has a question. No. Okay. Yeah, so only the pedicle screws are computer assisted, because I saw the demonstration by Pacific Surgical. They already have also computer assisted rod bending. Did you use the computer assistance for the rod bending?
Only for the pedicle screws or the use on computer navigation, sir. For the rod, the primary surgeons did the rod bending, sir.
Okay. Any other questions from the floor? Yes, Nico.
All right, Daniel, with regards to other possible problems in terms of, since I saw that you were already having the patient try to stand, and in relation to Dr. Lumawig's comment earlier, what's the other major problem that you would have to expect, since this is a relatively young patient who has lots of years to live? Do you have an idea on any next likely problem, aside from the pseudarthrosis at the bottom? Are you familiar with PJK rates in terms of long constructs? So, sorry, just to cut you short, that's why for me, probably in relation to Dr. Lumawig's comment, TLSO brace would be very helpful, since proximal junctional kyphosis is a very nasty problem if you don't get to have if all of your segments in the middle are still moving. So that's the biggest concern kasi talaga, fusion. And I don't know how much of bone graft we're able to put, because generally in adult spinal surgery, deformity cases, one of the best things that they put in is actually BMP to help support and increase yung fusion rates to at least combat this pseudarthrosis problem. But then again, later on, your problem will be PJK. So, do you have an idea in terms of PJK rates in these long construct cases?
Thank you for that question, sir. Regarding the proximal junction kyphosis rate for these kinds of construct, I think I have to review on it, sir. I cannot tell you the exact percentage on it, sir. But point well taken, sir. Thank you very much, sir, for the question.
Okay, Jomik. Then PJ after Jomik.
If I understand, you did primary repair on the proximal dural part, and then you patched the distal, tama?
Yes, sir.
And how were you able to do a Valsalva after that? You weren't able to do repair distally.
So the dura patch was secured tightly over the distal segment, and then we observed for CSF leak when we tried to do Valsalva maneuver, and there was no observed leak at that time, sir.
Okay, all right.
Okay, maybe time for one final question from Dr. Medina.
Hi, good morning. I'm Paul Medina. I had a similar case for like this one, and the construct you have is very impressive. But my concern is that the one you have is a fairly active, fairly aggressive type of ependymoma, and so that's why you saw that scalloping. You had the construct that was strong enough for that of the immediate post-op, I think. But is there any way, like, for example, in these cases, some oncologists would like to have irradiation in these patients. Do you have any suggestions or any ways or any additional, ano ba, anything that something additional that would help support your lower construct from the effects of irradiation, like say for example, additional lysis, loosening, ganun. Do you have anything that would add up to the strength of the construct if the patient would go irradiation and prevent loosening of the screws?
Sir, the question is if
Kasi
we are able to do
yeah, is there anything you can do aside from the good construct? Is there anything you can add to prevent further? Kasi for example, these patients might go to irradiation because of the aggressiveness of the ependymoma. So, ganito, would the construct itself last if irradiation was to be done? And if so, is there something else we as surgeons can do to prevent these types of complications, if ever?
actually, this patient underwent a few sessions of radiation therapy after post-op, and a good thing would be after radiation, the construct is still intact with no signs of any implant loosening. Regarding the question, if what else can be done to prevent what else can be done to prevent implant failure for patients who had underwent or will go radiation, I think doing a robust construct with additional fixation points could somehow prevent implant loosening from radiation.
Thank you, thank you.
Okay, would like to close the discussion for this case presentation, and thank you, Dr. Yu, for this very interesting case, and kudos to the team at Chong Hua Hospital for doing a very nice job. And